Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's March 2023 issue. There are 3 articles that have been selected as our Editor's Choice or Highlight articles this month. The Editor's Choice this month is an original article entitled Relationships Between EHR-Based Audit Log Data and Physician Burnout and Clinical Practice Process Measures. It is authored by Dr. Lottie Derby from the University of Colorado in Denver and colleagues from Mayo Clinic in Rochester, Minnesota. Burnout casts a long and ominous shadow on healthcare. Burnout impairs the professional and personal well-being of physicians, their commitment to and their care of patients they serve, and the mission of healthcare systems now and well into the future. Understandably, considerable attention is directed to the causes of burnout, with the electronic health record, the EHR, increasingly regarded as a significant contributor. Derby et al. Examined the relationship between EHR-based audit log data and physician burnout. Their study involved physicians in an academic department of medicine who had completed an annual program on physician well-being survey and matched their responses to EHR-based audit log data obtained between August 1st, 2019 through October 31st, 2019. The survey response was 77.5%, with some 39% of physicians exhibiting high emotional exhaustion, 22% high depersonalization, and 40% of physicians with overall burnout. Broadly considered, the mean number of in-basket messages received per day were 26, with 4 messages for each appointment per scheduled day in the clinic. After adjusting for relevant factors, the salient finding in this study was that burnout and turnaround time to in-basket messages independently associated with the number of and the time spent in addressing in-basket messages, and the time spent in the EHR beyond the time committed to scheduled patient care. Another notable finding was that primary care physicians received twice as many messages as compared with non-primary care physicians, many of these messages involving the returning of patient calls. Response to patient calls is critically important and needs to be done in a timely manner. Returning calls, to directly quote the authors, is often unaccounted for by healthcare organizations and traditionally not reimbursed, leaving it as an add-on activity after a busy clinical day. This study also demonstrated that a larger volume of patient calls was associated with less timeliness in response to other in-basket messages and with burnout itself. The patient-physician interaction is an inviolate cornerstone in the edifice of healthcare. An advancement in the digital age, in particular the EHR, should strengthen this interaction and not, as in the case of aspects of in-basket, detract from and burden it. There is the need, to directly quote the authors, for new reimbursement models that enable replacement of the traditional face-to-face clinic visits with block time during the clinical workday for in-basket work, and new approaches to reduce the volume of in-basket messages received by physicians each day. Derby, West, and colleagues are to be commended for their seminal contributions to the field of physician burnout, and as exemplified by the present studies, for uncovering significant determinants of this tragic and growing phenomenon. Our first highlight article this month is an original article entitled High Sensitivity Cardiac Troponin T Elevation in Hypertrophic Cardiomyopathy is associated with ventricular arrhythmias. It is authored by Dr. Daniel Bergsack and colleagues from Mayo Clinic in Rochester, Minnesota. Hypertrophic cardiomyopathy imposes a risk of sudden cardiac death approaching 1% in referral populations, with lower rates in unselected populations. Risks for sudden cardiac death include, among others, a relevant family history, a personal history of syncope, arrhythmias, or cardiac arrest, ventricular dysfunction, ventricular aneurysm, wall thickness, and myocardial fibrosis. Bergsack et al. Point out that biomarker data have yet to be incorporated in such risk assessment, and while a limited number of studies suggest that biomarkers such as high sensitivity cardiac troponin T may correlate with certain sudden cardiac death risk factors, such studies generally exclude relevant subsets of patients with hypertrophic cardiomyopathy and do not utilize sex-specific high-sensitivity cardiac troponin T cutoff values in the analysis. In their study involving a referral population with hypertrophic cardiomyopathy, Bergsack et al. Correlated prospectively determined high-sensitivity cardiac troponin T levels with clinical characteristics, comorbidities, risk factors, prior cardiac events, and findings from relevant evaluations. The population included patients who underwent prior septal myectomy and those with coronary artery disease. The majority of patients in this study had elevated high-sensitivity cardiac troponin T levels, and elevated high-sensitivity cardiac troponin T correlated with such sudden cardiac death risk factors as septal thickness and non-sustained ventricular tachycardia. Patients with elevated high-sensitivity cardiac troponin T levels were at risk for cardiac events, the latter based on a composite index encompassing appropriate ICD discharge, unstable ventricular arrhythmias, and cardiac arrest. This association was no longer discernible when sex-specific cutoff values were not utilized in data analysis. As there are recognized sex differences in outcomes in hypertrophic cardiomyopathy, with worse survival in women, Bergsack et al. Emphasized the need to employ sex-specific cutoff values for high-sensitivity cardiac troponin T levels in studies of hypertrophic cardiomyopathy. An intriguing question is, why does high-sensitivity cardiac troponin T correlate with ventricular arrhythmias and other cardiac events in hypertrophic cardiomyopathy? In this regard, Bergsack et al. Point out that the variable in studies of hypertrophic cardiomyopathy that most frequently associates with high sensitivity cardiac troponin T is ventricular thickness. Certain pathophysiologic processes, for example, oxygen demand supply mismatch, microvascular dysfunction, and cell death and attendant fibrosis, underpin both increased high sensitivity cardiac troponin T levels and ventricular hypertrophy. Cardiac fibrosis is recognized as a driver of ventricular arrhythmias, thereby offering a linkage between elevated high sensitivity cardiac troponin T levels and cardiac events in hypertrophic cardiomyopathy. This timely study by Bergsack et al. Significantly advances the field of high sensitivity cardiac troponin T as a biomarker for cardiac events in hypertrophic cardiomyopathy, and uniquely underscores the application of sex-specific cutoff values for high sensitivity cardiac troponin T in such studies of hypertrophic cardiomyopathy. Our second highlight article this month is a review article entitled Approach to Disorders of the Gut-Brain Interaction. It is authored by Dr. June Tomei and colleagues from Mayo Clinic in Rochester, Minnesota. The gut-brain interaction is bidirectional, involving on the one hand the gut wall and luminal contents with, on the other hand, the central and peripheral nervous systems. This interaction underpins physiologic functioning of the gastrointestinal tract and may be perturbed by diverse stressors, including psychosocial stress. Disorders of the gut-brain interaction, previously termed functional gastrointestinal disorders, are common in clinical practice, not infrequently distressing to the patient, and can be challenging to effectively manage. In their review of disorders of the gut-brain interaction, Tomei et al. Outlined the approach using an appealing mnemonic of the 5 E's. First, exclusion of organic conditions. Second, empathy for the patient. Third, education of the patient. Fourth, expectations of management. And fifth, establishing appropriate management. The authors emphasize the importance of the history and physical examination as the foundational step in diagnostic evaluation, a major objective being the exclusion of an underlying organic or structural condition. Certain alarm symptoms and red flag signs from the history and physical may point to structural diseases and the need for appropriate evaluation. While there are no definitive tests for disorders of the gut-brain interaction, the Rome 4 criteria lends support for such diagnoses. Empathy and validation of the patient's symptoms promote a trusting patient-physician relationship, in the course of which the physician should be cognizant of the triggering events that provoke or exacerbate symptoms, the risks of medicalization and fragmentation of care, and the adverse effects of disorders of the gut-brain interaction on the patient's work and personal life. Appropriate education by the provider enables the patient to gain insight into their condition and the feasible expectations of management. The latter includes pharmacologic approaches and non-pharmacologic approaches that include dietary ones, avoiding triggers, physical therapy, and cognitive behavior therapy, and perhaps alternative medicine. This review by Tomei et al. Expertly addresses the challenges and management of disorders of the gut-brain interaction and provides certain concepts that may be broadly applicable to functional disorders involving systems other than the gastrointestinal tract. You can access these highlights and editor's choice articles free of charge during the entire month of March. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find links to our social media by clicking the buttons at the bottom of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights and our MCP 60 seconds video article synopses. Our website also includes our Mayo Clinic Proceedings issue summary and author insight podcast recordings, which are available from our website on our homepage as well as through iTunes. You will also find our online-only feature and many news stories posted in the News from the Editor carousel at our website homepage that are based on articles published in Mayo Clinic Proceedings. And finally, you'll see other free content as well as articles published online in press. As always, we greatly thank you for your interest in and support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.